Good evening, everyone. I am presenting the case of a 58-year-old male, resident of village Kariawal, Gurugram, property dealer by occupation, educated up to 10th standard, and admitted with us with informant being patient himself and is reliable. Is a known case of hypertension and CKD stage 5 on continuous ambulatory peritoneal dialysis since June 2019. Now he presented to us with chief complaints of swelling over both feet since 15 to 20 days, and shortness of breath since last 10 days. I would like to date my history to 5 years back when he was detected to have high blood pressures and renal dysfunction on evaluation of headache on and off of 2 months. Blood pressures at that time was around 170 to 80 mmHg, the upper value, that's what he remembers, and serum creatinine was around 6 to 7 milligram per deciliter. On further evaluation, he was told to have both small clinics. There was no history of edema, body urine, hematuria at that time, no history of chronic use of painkillers, no history of recurrent UTI or passing stool in urine, no history of fever, rashes, joint pain, no history of chronic exposure to heavy metals or radiations, no history of any blood transfusions, bone pains. He had good urine output, had no shortness of breath, no edema. He was explained regarding the need of renal replacement therapy and various options of it. And AV fistula was created on his left arm, and then he was continued on some oral medications, including two drugs to control the blood pressures. Around 20 to 25 days later, he developed uremic features in form of nausea, decreased appetite, generalized weakness, and then he was housed for dialysis initiation. He opted to go for peritoneal dialysis, so he was admitted and CAPD catheter was inserted. At that time, he was found to have severe anemia, so 1 minute blood transfusion was also given. Procedure was uneventful, and he was discharged on day 3. He was started on CAPD around 2 weeks later. He and his wife were trained to conduct the exchanges and to maintain the record book and to assess to take care of the exit side and the catheter. His prescription at that time was 1.5% dextrose 2 liter bag, 2 exchanges of 4 hours each, and 1 exchange of 2.5% dextrose 2 liter bag. His ultrafiltration with the 1.5% dextrose bag was around 150 to 200 ml each, and 2.5% dextrose 4-hour duration was 700 ml to 800 ml. So his total ultrafiltration used to be 900 to 1 liter per day, and he had good residual renal function in form of 1 to 1.2 liter urine output per day. He continued CAPD with the above-mentioned schedule, and he maintained his record book, practiced catheter and NSAID care for next 4.5 years. During these years, his BP was well controlled with oral medications. He was asymptomatic with stable weight, good appetite, and urine output. There is no known history of pain, abdomen, cloudy effluent, or hospitalization during this time. Now he presented to us with complaints of swelling over both feet since 15 to 20 days. It was insidious in onset and gradually progressive. He realized it when he was having difficulty in his sleep. He was not able to fit into his slippers. And around a week later, he developed shortness of breath also. Gradually onset progressive. Initially, it was during his walking sessions only, but later during routine activities, he had difficulty breathing. Now, since last 3 to 4 days before presenting to us, he had shortness of breath even at rest, and he was not able to lie down comfortably. He also complained of cough since last few days, which was productive. The sputum was whitish in color, frothy, not foul smelling, not blood stained. There was no history of fever, chest pain, palpitations, no history of yellowish discoloration of eyes, skin, or pain abdomen, no history of cloudy effluent, vomiting, no history of constipation, slow or positional drain, no history of outflow pain. There was no history of any localized swelling of abdomen or genitals. On direct questioning, he gives history of decreased urine output as well since last 4 to 5 days, both in terms of frequency and volume. There is no history of loose stools, vomiting, fever, no history of NSAID intakes, and no history of pain, abdomen, or lower respiratory symptoms. There is history of irregular and inadequate dialysis sessions since last 1 month. Earlier, he used to conduct 3 exchanges per day, which since last 1 month he has reduced to 1 or 2 exchanges per day. Um, that's all.
So, can you some what's your diagnosis?
58-year-old male, hypertensive, CKD 5 on CAPD, volume overload,
Historically, you see the patient as what is low.
Yes, sir.
Why do you see that?
Because patient presented to us with the history of bilateral period edema as well as
Short list of
um,
what happens, you said recently there will be a decline in your output. What chapter of attrition that you was bringing?
yes, sir.
Remember mentioned last 1 month since you reduced the exchanges?
Yes, sir. Yes, sir. His total ultrafiltration now reduced to 200 to 400 ml per day.
Was there weight gain? That's what they did also.
Yes, sir.
Mentioned that mentioned these things. After the gain weight,
Yes, sir. He did be.
was this weight gain.
Sir, usually weight used to be in 65 to 66 kg. Now it's presented to us 71.6.
6 kgs.
Uh-huh.
That's important information. Right. Anybody else? Any other questions? Yeah. Let's see. The hypertension is that how many years?
Sir, hypertension since 2019.
That's 4 years.
Yes, sir.
June 2019, he had the CBD checked up.
Yes, sir.
When he was detected to be hypertensive,
So just 3 months back for me, the renal dysfunction and hypertension, they were detecting both together only.
you mentioned that he got both urine output, renal output, residual renal function. So how did you estimate the residual renal function? What? How did you come to the conclusion that the residual renal function is about?
It's by like urine output besides
Withdrawal or something else also. It could be an indirect estimate. Just you have not. So now what I've tried to get to is that how do you do the estimate residual renal from other these patients? What is residual renal function? To start off with, some people I think must be visiting new. How many of you are first timers?
About 5, 6 or more. First years?
First year, I think 2 hours. Yeah, right. You had second year.
Yes, sir, just entered third year.
So what is residual renal function?
And what is its significance? What is the significance of it? Residual renal function is the leftover GFR. What are the leftover GFR?
How do you estimate?
What do you estimate?
So, to estimate the EGFR, we can still we have various formulas like CKD formula and GRD formula, and also we can measure the EGFR by measuring serum, creatinine, serum urea, and
Simple. I don't understand anything. I'm a first year student. If I ask you that it is 58-year-old male, what would you do and to tell me the level mouth? Serum creatinine would be fallacious.
yes, sir, yes, sir.
Because you are already there is an intervention going on. You are doing peritoneal dialysis.
Yes, sir.
So what would be a better estimate? How would you estimate? Your serum creatinine is too simplistic.
What are the other functions of the kidney?
Anybody else?
Okay, nitrogen, yeah. Like we are like
Okay. No, we are talking about residual renal function. How are we going to assess residual renal function in this patient?
So we calculate the serum urea and the urine ledger, we calculate urine clearance,
Yeah.
and that is the formula for KRC by the
So urea clearance, not creatinine clearance,
big the
or both,
both
or a mean of both. Yeah.
we both mean of average of both.
Average of both. So you do it. So you do a 24-hour urine clearance, urine estimation, do a urea estimation, do a creatinine estimation, and at the same time do serum estimation. Ideally, you should do an average of both to arrive at a residual range. So, what is the importance of residual renal function in patients and
CKD. CKD is usually still disease.
then we'll come to dialysis patients, especially CAPD patients or CAPD patients. What is the significance?
What is the significance of residual renal function?
Who has a good residual renal function, they have better hemodynamics stability. Their hormonal and metabolic functions are also there of kidney, so they are
What?
well.
And there is more dynamic stability. What?
And
What benefit do they have against someone who has
the middle molecule clearance is then wider than
So, which study are you aware that for the first time highlighted the importance of residual renal function in CAPD?
So can we start today and silent?
Yeah. All right. So now that we have, discussed how do we estimate residual, they're not audible.
Come forward. There are
Again,
again.
yeah, the last thing we will have back.
Yeah.
All questions will be direct.
आगे आ जाओ. We'll not bite. come आगे भी आ.
वो छोटे से वाले में बाइक क्या पूछे? This is for recording, sir.
अच्छा. Okay.
सब ठीक हो जाएगा. So alone saying that you shouldn't use these terms loosely. You can say yes, urine output. Urine output is a surrogate.
This is again बात हमारी.
Just say okay, yeah, the point is well taken, but if
But you have diabetics with creatinine of 6 who are anemic, and you have CIN patients at to the creatinine of 12 who produce 1 liter of urine. Why is that so different? First year, anyone in first year? There's a diabetic who's at a creatinine 6 put on to dialysis because he's either anemic or hypervolemic. There's a patient with tubular interstitial nephritis. Creatinine is 11, 12, still maintaining a urine output of 1 liter. How's that possible?
Because of the concentrating effects of the tubule.
So this is his actual JFS. This is not urine. The tubules are unable to concentrate anything. Whatever is coming, the tubule is pushing out. So if this fellow has diarrhea tomorrow, he will still produce 1 liter urine. He will not be able to preserve it. So that's why. So what? The other thing. What was the basic disease you think this patient had?
He had hypertension, he had preserved urine output, he had severe anemia, so chronic interstitial
Again, bilateral shrunken kidneys.
Yes,
Yes,
bilateral form.
I was also kidneys was. I guess hypertension is controlled with just 2 drugs.
and to the extent of hypertension, you said, no?
Yes, sir.
So it's very likely that it's tubular decision.
Yeah. So coming to your diagnosis, you think it's just volume overload or it could be heart failure also?
You didn't mention anything about his fistula. I was for a couple of what cells after. This is very good. This one has been managed exactly how a textbook says a CKD patient should be managed. PD first, make a fistula, and thereafter wait. What happened with fistula? Was it still functional?
Yes, sir. CPY.
What is the problem with the fistula which is left there working? And where was the location of the fistula? You didn't mention that.
It's the left forearm.
Forearm is, it's a radiocephalic or a brachiocephalic?
Radiocephalic.
Radiocephalic. So ideal, I would say this patient has been managed ideally. He's got a distal fistula well in place. Well in place and it's functional. Yes, was there any tortuosities or anything? I mean, of course, that would come in examination, but historically the fistula has been functional.
Yes, there was
So what happens with the fistula? In a patient who's undergoing anemic CKD, 58 years old,
high output cardiac.
cardiac urine will be there.
But in your differential, with your diagnosis, you have been very dogmatic.
Dogmatic
Nothing
is
but
utter
figurative overload only.
I asked about history of any chest pain or palpitations or the swelling of the chowan.
swelling of heart.
Yeah.
You should give alternate differential diagnosis. What about पता लगा it's just hypoalbuminemia? That is another problem that is associated with CKD. Albumin 2 है. ठीक से dialysis नहीं कर रहा और कुछ खा भी नहीं रहा. We haven't asked why has he stopped. That is another question. Why after 4 years of being such a good patient, I mean he's one of the rare patients who's lasted 36 or 48 months without a single
Correct, 96.
I mean, everything about this patient is textbook. How exactly a CKD patient in ESRT should be managed? What happened in the last 1 month to suddenly make him so indisciplined?
So actually he thought he was maintaining so well, so he could decrease the dose. He was not needing dialysis further. That's what he thought.
And has there been a decline in his urine output over the last 4 years?
Yes, sir. That's history on that was not a street from when
No, but
he told us. Yes, sir.
yes, you have to present that over time and urine output. has
Yes, sir. I
declined.
told him.
So that she said in the last few weeks there's been a reduction in frequency add-on.
Yes.
It almost seems like it just happens now. पहले दिन wasn't a gradual decline.
No, sir, it was not a gradual decline.
Suddenly it was
So what could be the triggers for sudden decline in daily function? Well,
So any episode of hypovolemia, like diarrhea, hypotension, any exposure to nephrotoxic drugs or radiations, or
I will explain.
contrast,
Read your podcast.
yes, sir, or overzealous use of diuretics, which is sometimes there in CWD patients,
What else? What other parts?
or any episode of sepsis.
Yeah. Illustrates.
Yes, and that's what I say, yes.
So the other thing that you should have, I don't know, you haven't mentioned the dietary history of this patient. That's what I was coming to. Albumin. What about his dietary history? What kind of diet would he eat? There was, when we have finished history, all the years. History taking is low, so diet has to come out as a separate thing. That what do you think is enough protein in calorie? Is he a vegetarian? What is the predominant source of protein?
Yes,
You have taken? Okay, then.
Yes.
Then we went. Let's go. Finish talk.
So past history, history of pulmonary tuberculosis 22 years back, for which he took ATT for 6 months. There's no history of diabetes, any cardiac illness or stroke. No history of recurrent UTI in past. No history of any abdominal surgery in past. Family history, nothing significant. In personal history, there's no history of constipation, diarrhea, normal bowel habits. He is a chronic smoker, reformed smoker, and he takes the vegetarian diet.
He's a reformed smoker. He's quite smoker.
Yes, sir, this is 1 year. He takes vegetarian diet, he takes strict vegetarian diet, and his sleep pattern is normal.
And what else protein is taken?
What is this protein? How does he get his protein?
And his caloric intake. Do you think it's optimal for his heavy shakers?
So first years, पीछे कौन है first years? Please raise your hand. Yes. What should be the protein intake of a patient who's CKD, not dialysis? Please sit down. Please practice that. CKD, CKD on peritoneal dialysis, CKD of hemodialysis.
So first just CKD.
No, but
How much is the normal protein requirement for an average adult?
what about the package?
Pardon? Let her ask. Yes, it's okay. It's a class. You can make this step. So, you said 2 grams. 2 mg. 2 grams. It's double. It's half. 1 gram.
ICMR guidelines are
1 gram per kg. When a patient has CKD, what do you do with the protein intake?
YSC
Increase it.
8 to 1. Don't say it.
Wait,
No problem.
no problem. You will reduce it.
Take all your mistakes here, not in the exam.
So CKD requires protein intake to be
0.8.
by how much? 0.8 grams.
Point.
Now the patient has come back onto dialysis. One patient gets onto peritoneal dialysis, the other patient gets onto hemodialysis. Is there any difference in their protein? One at a time.
1.2 grams per kg for, and this is for PT.
Peritoneal dialysis.
1 gram for the
You can increase it to 1.1 also for hemodialysis because even that's a catabolic process.
What I would say it is actually 1.2 for you would have not mistaken, 1.2 to 1.5 for peritoneal.
During peritonitis, we hike it to 1 point. So when the patient has peritonitis, at that time you have to hike it. What is the average loss of amino acids and programs in a pre-exchange eating for a patient per day?
5 to 10 grams.
8 to 10. Roughly 8 to 10 grams. And how much protein does one egg consume? Standard reference protein according to ICMR? 6 to 8 grams.
And dal on peritoneal dal is how much?
PD patient आएगा तो ये सवाल पूछे जाएंगे. You should have a clear idea. Meet your dietitian, get these things noted down. You have to do a quick dietary survey of the.
And even a chemo also.
You also should do, and do not keep diet in such patients and personal history in the past. It is important to bring this history again.
Diet, say especially diet history, because he's already a vegetarian, and the vegetarian patient to it.
Proteins.
What is the problem with vegetarian protein? How do we assess the efficiency of a protein dietary?
What does that protein taste?
I'm sorry.
And
Net protein value or net protein utilization. So what happens with vegetable protein? Soybean is the richest source of protein.
great proteins or direct essential
They cannot be, not just even animal proteins are incomplete. They can't be completely absorbed.
So
So the net available protein in a vegetarian diet is much less. Second, most vegetable foods are associated with phytates. Phytates tend to bind both iron and protein and hence they reduce absorption. Which is why we say leach. Your entire Viva could go into diet and CKD. What advice do you give to a CKD patient? How do you reduce potassium in his diet? How do you reduce phosphorus in a CKD patient's diet? They will not even want to stay a period of it.
Alright, examination, then we come back to patient.
So anything important about this 22 years ago tuberculosis? What tuberculosis did he have? How did tuberculosis?
Yes, sir. General tuberculosis.
So we don't know why he developed interstitial nephritis.
Yes.
It's a very slowly progressive. It doesn't look like that he had acute interstitial nephritis episode and then progressed to chronic interstitial nephritis. He's never had renal calculus. He does not have history of reflux. He's not had recurrent pyelonephritis. Yes. Where does he belong? Delhi.
Yes, sir. In Gurgaon village.
There is no family history of. Then CMAD, we have that is a geographical location that you wouldn't show. What was is ATT associated with interstitial nephritis?
Hypothesis.
Yes.
This happens in
This is associated with it. Yeah. Yes. You never know.
What are the other, any other CKD associated with the cysticercosis?
Continue.
Granulomatous interstitial.
Or anything else, somebody else?
Amyloidosis. Yes.
So that is chronic suppurative condition, lung abscesses.
But
So you can have a second amyloidosis.
I think he had amyloidosis. I'd like all of you.
Help with the papers.
In fact, in some of the earlier papers, it's almost all of secondary amyloidosis.
It's a secondary amyloidosis.
I should be a doctor.
Can you have GUTV? Could this have been genetic evidence of first?
But I nearly suffer.
Yes.
He's been treated with it mostly.
Yes, sir.
And then he would have investigated more with neurological symptoms other than nephrological.
Yes.
GOTP is typically the pelvic calcium system of the blood. Yes? So you should be ready with these answers. The job the examiners to speak straight away कि इतने बिल्डअप अपने आप.
So amyloid, what the amyloidosis? You just said tubular interstitial nephritis.
Amyloidosis में क्या?
What is the presentation in amyloidosis? Secondary amyloidosis, how do they present?
Sir, anemia will be there.
What else?
Nephrotics, you cannot accept it. Nephrotics and toxicity.
Yes, Professor, you
But kidney size is
The kidney side.
cytoplasm. It makes it all very unlikely that it's still very silent. So it doesn't appear to be at the face of it, secondary amyloidosis probably since high.
Anything else? What about vaccination history? Is it important?
yes, sir.
Vaccination in CKD is an entire almost an exam. So everything. अब कैसे क्या स्टेप लेना है? ट्रांसप्लांट से पहले कैंसर बाहर का कुछ बूस्टर के बाद. What all vaccination do we give our direct patient before he gets hospitalized?
So hepatitis B vaccine readings, pneumococcal vaccine readings, and then influenza vaccine, 2 like you can
What do
wait
you require for the year?
yearly basis.
What else?
And
Just
Yeah, so that vaccination now is also on the required
hydration.
So keep us vaccination history. Make sure that you confirm that he's fully vaccinated.
accept. And they should come out separately.
Yeah. Because the significant part is, God forbid, it's a either filtration failure because of worsening membrane. Then if you want to switch him to hemotypes, if he's not been vaccinated, you now have type 2 at least initiate vaccination. You'll be surprised how many patients actually fall in the gap when somebody sees the patient and starts on something and forgets the vaccination. There are some things that you must write on the first page of an already goes on a CKD patient. What do you think is the basic disease? I've always the first thing. The second thing is what do you think will be onset, if you possibly go. The third thing is fistula to be made. By which date? Fourth is vaccination. And put down the doses there. Who's the first chair here? 1, 2, 3, 4 थे आप खड़ा कर लो नहीं आपको देख लिया well yes yes what's the hepatitis B vaccination schedule for CKD patients?
C016.
016 that is for normal for everyone.
C4
0126 is that all? What dose? What are the dose?
40 mcg.
40 micrograms That is 20 micrograms in each shoulder. It's not given in the buttock, it's always given in the deltoids. So it is 0, 1, 2, and 6. And pneumococcal?
10.
Next to you. How do you vaccinate a CKD patient against pneumococcus?
Yep.
How many vaccines are there for pneumococcus?
Then
Then first year. Yes?
PCV 19.
I
13.
And one of these 30.
Might be 3. So which one do you give first? 13. And after how many weeks do you give the 23? What if you forget and give the third 23 first? Then you're going to, can I repeat this, fix the channel with this one?
after the real have that reduction. It's okay.
I've got a
765 and
for that patient, you have by mistake, your number has given 23. Now the patient is confusing concept that you have to figure out the taste here.
certain areas when it
Yes, you wait for 1 full year. I'm not going to find out the reason why, but CDC says you have to wait for a full year and then you make part.
And what about shingles? What does the shingles vaccine or does the
Funding also not good, is it good?
what are the doses?
Numbers.
0.5 or 0.5 even at 0.0 second one. 0.2 second one. However, so examination that does me come back to the case.
So your diagnosis is he's post-operative tubular interstitial disease, CKD 5B or
Paralysis. Since I was
how you feel he has developed fluid overload secondary to what? Inadequate dialysis? Worsening reservoir function coupled with inadequate dialysis and nothing else.
mobility facts.
So I examined the patient in general physical examination. I examined the patient on day 3rd of admission. Patient is conscious, alert, sitting comfortably on bed. Height 168 cm, weight 71.6 kg. His vitals are
Height weight बता दिए BMI में बताओ. That gives us a much better idea of how the patient is.
BMI 44.3 kg per meter square, thin build. His vitals are blood pressure is 160 by 92 mm Hg.
What?
162 by 90 mm Hg in right arm supine position. Pulse rate is 80 per minute, regular normal volume. Vessel wall is condition normal. Low radio radium floral delay. Respiratory rate 26 per minute. She is at febrile. Pallor is present. There is no actual sign of clubbing or lymphadenopathy, thyroid swelling. Bilateral pitting pedal edema present. Local temperature not raised, non-tender, and oral cavity normal. There is no spine and genitals are normal.
The activity is normal.
Yes, sir, no swelling. No swelling noted at hernia side.
But something else you have doing. One of the extent of the pain. It's only till the shin, it's to the knee, it's on the thighs. The vertical extent of the pain. See, that's what we don't have.
So I guess that is up to the feet and ankle only.
To see it. So, anything else in the examination that you would like to show with your diagnosis of fluid overload?
JD.
The JLP?
Yes, sir.
Who? That goes without saying because we are thinking of cardiac failure as a possible difference.
Diagnosis still fair.
Both fluid overload and cardiac failure could solve the right in JLP. But the JLP is very important.
Fine. So how do we investigate this patient now? So bad.
See,
Instructions.
Your examination okay?
so systemic working. For abdomen examination, I examined the patient after drainage of the TB fluid on inspection. Abdomen is flat. The circular center is position circular. There is no fullness of the cranial same. A pouch containing PV catheter is seen below the umbilicus with exit side facing down and laterally on the left side. No scab, rust, redness, swelling or discharge present at the exit side of the catheter. No redness or swelling present on the tunnel side. On palpation, abdomen was soft, non-tender. No tenderness or discharge on the tunnel or exit site. No organomegaly. On respiratory examination, my inspection chest was symmetrical in shape. Respiratory movements were equal, trachea center in position. On auscultation, bilateral air entries present. Post crepitations were heard in bilateral, intrascapular, and infraxillary region. There was no leaves or bronchial GP was used of present. Yes, sir. And cardiac examination was within normal limit. Examination of fistula, yes,
What kind of serious pallor if he exposed heart what I would say. Should cause some say hypertension.
yes,
No cardiovascular. Anything you might have it was thick cut.
yes, sir. A vital impulse was located in the left fifth intercostal space.
इसको कम से कम एक फ्लो मूवमेंट तो होना चाहिए. The voice.
Now,
This is pallor.
fistula time, fistula time.
MBBS का स्टूडेंट भी दो था. पहले है फ्लूइड ओवरलोड है. तो पेशेंट का हार्ट रेट थोड़ा सा की तरफ बढ़ा हुआ है. Hypertension है. You would have definitely got a flow over of the pulmonary sections. Be careful always. Look out for these things. You may have actually had an LVS3 if you was day. So which would even further strengthen your case to have measured as fluid overload or failure or whatever. And of course, inadequate diagnosis. You have seen them on the third and the difference. They can't even There's only one thing that the nephrologist uses was stethoscope. It's like pericardium. बाकी सब हम वैसे ही सोच.
Say,
The what?
examination of AV fistula. On inspection, the scar of AV fistula was present on the ventral aspect of the left forearm. No swelling anywhere on the face, left shoulder, left arm, and forearm. No prominent veins present. On palpation, a pulse palpable at the fistula site. There is no tenderness and a continuous.
Is it the pulse? Is that how to describe the feel of a fistula?
Does it bring?
If it's the pulse, then I can't be worried.
Continuous. Yes.
I want
And what kind of smell is this?
So it is continuous thing.
You say these things spelling. You could feel the continuous strip till where? And is it important? You examine a fistula. Anyone? एक पेशेंट का फिस्टुला का थ्री यहाँ एक का यहाँ फिस्टुला is over here radiography. What is the importance of the thrill being fit farther and farther away?
Show that to stay in such.
Fitted. On the other hand, it shows the fistula is beginning to fail, it's closing. Yeah. That's why the turbulence is so much that what makes more sound? On the other, high pitched noise. Narrow or just or a larger one.
Nice.
और जब पतली दीवार से जाके खिड़की से आती ज़्यादा आवाज में आती है. If you open the window, that whistling noise goes away. Similarly, when blood flows through a narrow orifice, it will create turbulence farther away. So if you can feel the thrill or hear the turbulence farther away from the fistula, it tells you that your fistula is venous stenosis is beginning to occur. The artery is working silent. Understand how it works? The artery is getting enough blood, but the vein is not letting enough blood through. Correct? So it's very important to tell us the thrill is strong, but it is felt locally and it is dissipating very quickly. That means the venous system is patent without any back pressure. Yes? Pain.
On auscultation, do you invite it? Fistula sign.
Again, you should go further ahead. Like say, where can you hear? What's the rule of 6 for a fistula? Some rule of 5.
what?
Pardon?
6. One minute.
1 minute, sir. 1 minute, sir. Yes.
It's just lovely things.
Then should be learned far back further than
So fistula should be 6 weeks. I know. I have about
Oh, the past, that should be the last thing you say. That is for use. One day, give us
as MSC deep
6 mm under the skin.
and 6 mm of width of how these are, which is each your weight, and 6 centimeter of straight
Straight force of J per hertz. And the last 6 is 600 ml per minute. So the first 600 per minute. They were for security.
6.
Some people quite rule of 5 millimeters, 5 millimeters, and 5 millimeters of it. So you have to understand what's the cardiac output in a minute? 5 liters. See, when you ml per kg, na? 5 liters, they say 500 every ml minute is leaking from here. So you're increasing the cardiac output by 10. When you hear what happens? What is the flow through a brachiocephalic fistula? At least 1.5 liters a minute. So 30% of my cardiac output is being short circuited screws. Can you imagine the amount of volume overload of the heart? Okay.
So after our history and examination, our
Neurological system short circuits. Inadequately dilates facial time. This is specific negative history corruption with telling us what. JCS तो बता दिए alert हो गई है.
South Africa. No, focal neuropathy.
Inadequate dialysis में क्या होगा? Neuropathy. Neuropathy. Anything else in a patient who's using it's not me that. Okay. Rectal neuropathy is very likely. What I need to say is keep your wife open. Every suggestion, every possibility of a water CKD can go to any system. Either diabetic, either hypertensive or clogged fatty. Ideally, you would be expected to see the fundus at least one. Undilated, but at least fundus they show. So, weeds, diabetic, 100% you will see the fundus. Since there is no history of diabetes, but this patient still have diabetic nephropathy, the kidneys were normal size. The kidneys were normal, let's say the kidneys were normal size. The patient doesn't have a history of diabetes, he was due glycemic very clear. His creatinine was 6. The patient still with diabetes.
yes,
Right?
all this because as the CKD progresses, the glycemic control is worse. I was a patient because
Why did the diabetic patient become due glycemic as the real function was this?
because the insulin gets dies.
Insulin gets split, half-life increase. That all? Not right. Insulin sensitivity remains the same. It is a half-life of insulin, so the amount of insulin in circulation continues. What is the areas? But
Gluconeogenesis decrease.
very cool. How much of gluconeogenesis is contributed to the kidney? Which is the main organ from gluconeogenesis? Liver. In your opinion, between the liver and kidney, what is the ratio? In fasting state and in fed state? 80-20 in the fed state, fasting state. Fed state we can. Be surprised. It is 50-50 in the fed state, and the kidney contributes the larger amount in the fasting state. The kidney is a very important source of gluconeogenesis. So not only is the half-life of insulin increased, gluconeogenesis goes down. So when the patient gets hypoglycemic, there is very little gluconeogenesis happening from the kidney. The liver will still contribute, but it may not be enough. What else? The patients don't eat. They don't eat anyway. CKD हो रहा है. Which is why they will become euglycemic. And then wax outside will tell them, chip up a diabetes cheap. And that's how they compose. Almost 5% of CKD patients reaching the nephrology clinic who are diabetic could be euglycemic on arrival. And could be detected either a fundoscopy or a renal biopsy that was done because they have the whole size kidney, the different diagnostic tests of the care. Of course, there will be proteinuria, that is expected. Hey, perhaps. The fundoscopy is important. So the natural history of modes of progression of the CKD will not happen like this if you was a diabetic. So this is the investigation board is yes, how would you how would investigate it?
First, the basic investigations, blood investigation. For this, we have a functions test and the complete hemogram. So you got given any history of pain, abdomen, vomiting, or cloud liquid.
what will you do? What are you out? Have you ever, by the way, you said you examined this patient after draining the fluid. Did you examine this fluid?
Yes, sir.
So how was that? You can describe it to us. How was the bag? Raised like cat up.
It was clear and
So it didn't look turbid, there was no blood, there was no fibrin, there were no experiments on the problem. How do you do a quick, how do you tell your patients with this?
by keeping the bag on a newspaper, we wanted to be able to see the happens.
Nowadays the bag has
Yeah.
one side pieces,
You said
the other side is clear with a clear stripe through it. So that yes, with you. So it acts like a convex lens. So if your patient keeps it upside down, he'll not be able to see anything. Supposed to blur it out exactly, the clear part is above and that's clean stripe. What should he be able to read?
small parts of it.
Not small. It's the headline of a newspaper. It's the headline of it. That's enough. Patient tells you रोज सुबह का जब fluid है, उससे headline नहीं पढ़ा जाता. पर दोपहर को रात को मैं ठीक बना रहा हूँ. What is the problem?
So that's because of the presence of
Is it normal or is it abnormal?
but still no,
The ninth word, the longer text is very likely normal. Where do we go now? Recover?
like children's strand.
Yeah. Some secular material, femoral strands. But most likely femoral. Which is why we describe to put femoral off and out into the bag. What are the other causes of non-infectious causes of turbid object?
Cellular causes and non-cellular causes can be there.
Sorry?
Cellular causes and non-cellular causes
Right.
can be there. Use of high nickel chemical,
Some kind of an allergy to the feeding fluid. They could get is the physic response. Okay.
and there can be presence of macrophages can be there if a filter drained after a long dwell.
If you keep night dry, keep a patient tight and dry, the first drain that you will always get out. What else? Lady comes and says you, hemorrhagic fluid out. That's the first question you'll ask her.
Menstrual.
Yes, sir. Please understand when the lady is menstruating very often, and it does the peritoneum because the pelvis is congested. So it's very normal during the periods for the lady to have hemorrhage couch.
And maybe because of the presence of chyle in patients having
Yes, that's sure. Good.
So investigations, yeah.
So tell us, what are the please tell us the investigations? Let's start off with Farah. So we're very good. What they go close
search on investigation of complete hemogram. The hemoglobin was 7.1, counts were 8,900, and platelets were 23. And in renal function test, urea was 229, creatinine was 11.4, and the sodium was 131, and potassium was 12.3. And
What are the other investigations that would be set in the bike history?
so serum albumin,
Very good.
so for this patient it was 2.8.
Okay. What else?
Sorry, first.
Yes, first years. Why are we asking these questions? What is the other question, other biochemical report that you tell me? Other than alcohol?
Um,
The CKD patients?
Calcium from
No, that is, I'm not sure.
why
Which? You said that first. Which one?
lipid profile.
Why am I asking these questions of albumin and lipid profile?
nutrition man.
They are markers of nutrition. Very important. What is the MIA complex? In CKD, what is MIA?
Somatic planetary.
Atherosclerosis. Malnutrition, inflammation, atherosclerosis, all CKD patients are inflamed. Most of them, like in 58-year-old devout smoker, even an atherosclerosis. You add malnutrition to it, it's a very potent combination.
What is the importance of alcohol in these patients? And why are we so focused on?
So one because of they are marker of nutritional status, and also we know that in peritoneal dialysis loss of albumin is more or less compared to other hemodialysis. So
In general, alcohol is what? Considered negative.
inflammation micro acute phase reaction
Say that it's a negative acute phase.
rejection.
And it's a marker of poor outcome.
Again, alcohol, survival. What's the paradox of cholesterol and CKD? First years? What is the paradox of cholesterol and CKD?
Reverse the case effect.
There's a reverse. In the sense, normally we say in any population where the cholesterol is high, mortality is high. But in CKD patients, low cholesterol does not equate to better mortality. Why?
But
So it's a marker of poor nutrition. Yes? So what was this patient's total cholesterol? The other question that is usually asked is dyslipidemia in CKD. Dyslipidemia of nephrotic syndrome is different from dyslipidemia of CKD or dialysis. It is different from dyslipidemia of CKD renal transplant applicants. So please read this. Patients who get steroids, they have a different dyslipidemia. Patients who are nephrotic have a different dyslipidemia. And patients who are CKD or dialysis have a different, as in different components of lipids are higher or lower than here.
so yes, what else?
How much was the cholesterol? Sorry,
Yeah.
Do you have a worksheet in the sticky? I think it's in
but the fact that lot of info.
your better.
What are the investigations?
Yeah, in the biochemistry and you mentioned that.
You already said.
You said viral markers.
No, biochemistry. I'm not mentioned in the next thing is CKD. After nutrition, after hemoglobin, nutrition, next.
Mineral.
Mineral disease. Yes.
So,
Serum phosphorus, calcium, and IPTH.
Yes.
Calcium was 8.2, phosphorus was 6.7, and IPTH was 990.
Okay. So anyone took second year? Second year, yes. Tell me. You're happy with this report of calcium of 8.2, phosphorus of 6.7, and in fact, PQ of time light. What is the first year? What is the normal value of IPTH?
later.
Anyone? Normal IPTH. Your lab comes normal with that.
Yeah,
10 to 40. But
60 to
70 to 110.
no.
It's between 70 and 100.
Teacher.
So the question basically is what happens to IPTH as CKD progresses?
Isophyt again increases.
Why does it increase?
So this is why then again,
Overcoming resistance of uremia. Yes, the uremic resistance to calcium. So to overcome that, so what is the normal range of rise which you should accept as normal in CKD5?
2 to 6 times the
I think this is what I remember. So 3 to 7 would be almost 800 tak. This is normal. Because this is required for the normal bone turnover in a patient who is uremic otherwise. But the calcium and the phosphorus. Are you happy with that report? But the product is it important? Is it allowed to be the calcium phosphorus product? I'm surprised that you're still using this term. I was taught this term when I was in my DOS. Take it out of the clinical guidelines now. So never use that.
What do the chemical guidelines is? What are the recommendations?
Phosphorus of the 1.5. See what that 5
4.5 to 5.5.
Yeah.
And calcium?
So 8.5 to 9.5.
8 to 10. Remember, what figures in your mind? 8 to 10 and 4.5 to 5.5. What is this way of taking of calcium?
So I claim you.
That's it. You have to correct it.
2 point distance.
So, for every gram of albumin below 3.5, you will add 0.8. So 3.5 is 0.5, so you will have to add 0.8 there. So it's about 9. So 9 seems to be fine. What is hyperphosphate? In that we teach his mind only has that. So he definitely has some amount of significant hyperphagia. Right. Anything else in the biochemistry? Or you're taking account? HB, you just told us completely more than 3 figures. Is that enough? Why do you think this patient is anemic? What all can that hemogram tell you?
Yes, sir. Can dancing lessons.
So tell me that it's very important.
Yeah. So what is the FCV, FCH, FCNC? Budget.
Let's get that.
Correct.
Loving this Mujari therapy now still lying. How do I know about treat of anemia? Have you been taking electropoietin?
Yes, sir.
Is regular with it?
Yes.
How much EQ is it take?
Sir, he used to take injection in the darbepoetin 40 mcg once a week. He used to take.
That's pretty good. It's what is darbepoetin? First years? Yes. Yes, tell me.
Longer
Longer acting. Is there something even more longer acting than that? You don't have to know the name, but what is the what we call chemical? Yes. Regulated.
So steroids.
Continuous erythropoietic receptor and active. Take a guess. Really white. Another. Steroids.
So do we have the iron series?
Yes, sir. It is. This serum iron for this patient was 34 and the ferritin was 590 and the T
519, 590.
590, sir.
Oh.
590 and total iron binding capacity was around 103. So T set the
Right.
Ferritins?
596.
You said it's 590.
Yeah, ferritin is fine.
By the
He said she has
No, 134 and 103 is the PIBC.
Serum iron is 34.
34 and PIBC is 103.
Yes, sir.
Keep going. So he said this.
So how much is the T-set?
34 is
34 by 103 is about 30 only.
30%.
So is this patient iron deplete, iron deficient, iron overloaded?
Yes.
Anyone? Yes.
that way.
Iron deficient, might be deplete. Further, they recommend that it's iron deficient.
Stored and
Stores are not adequate. Why is she got 590 of ferritin?
Sir.
How much is the normal ferritin?
Sir.
Again, like sweet, it is about 60 to 100.
So you're saying that
Yes. You said she's replete. Yeah, because T-sat is 30%. But the actual value of iron is low. Iron is closer to 60 in the normal, it's on the lower side. But the T-sat is so that's what worries me. T-sat seems to be fallacious, low. I can't. 30 ABC seems the T-sat fine. Normally the T-sat is in 200s and 300s. By that, you would have an iron, TIBC is at 200 or more. By that, the T-sat would be 10%. Can we have higher ferritin in patients on dialysis? It does it house. Why?
One centimeters.
So you will have these ferritins. Okay. Vital markers?
biomarkers for non-reactive, sir.
What other investigations will you do for this patient? So we definitely have anemia. He seems to be iron deplete. So the cause of this anemia could be CKD related only in the sense. What is the other one? Either he's not taking his EGO, or the EGO dose is inadequate, or including blood flow. Yes, I mean, that's the only thing that comes to mind. Or taking NCV is 110. The vegetarian. That is the next thing that comes to mind.
what else will you do? Ask for what other universities?
With the thorn, every complaint of cough as well, so HSX was also done.
No, we still at the anemia part.
Anemia we don't have.
And oils.
Doing visual.
The medical scale is the first thing you always figure out. What do you find is deeper deficiency in the medical scale?
Macros.
That follow sites and so on. But I took when we pick up bigger deficiency with copper, I was segmented. So what are the other causes of microcytosis? They got alcohol,
High liver disease.
hypothyroid. These are three common causes.
How do you define EPO resistance?
Sir, when there is not adequate response to the drawing, so like extracortical stimulating agent, despite after ruling out compliance and blood loss, and
So what is adequate response or adequate? I mean, obviously you have to give us a dose to receive not responding. Then you would call it EPO resistance.
take the 60 to 80 micrograms per kg.
What is the normal EPO dose? How to start a physically? How do you decide? I'm going to 4,000. Typical obvious rate is 4,000 twice a week. How did the magic figure of 4,000 twice a week come? What is the normal starting dose of EPO?
So it takes a lot, like per kg.
50 so?
100 units per kg.
It's 70 to 100 units per kg. That's what you start with. You divide it into weekly doses. You get about 450. Yes?
Right? So when you when quality resistance, what are the doses?
Go and then you can come to downward. But you can remember one, even if it is one, that's yeah.
If from a dose of 200 to 400 international units per kg, the increase in HB is not.
Sorry, 850 is the
That's some
100 to 150 units per kg per week is an normal dose. In 300 units per kg per week doesn't get you an adequate
1 gram.
1 gram rice over 4 weeks, provided the patient is iron replete that there are no other sources of iron loss and those things.
These are very, the standard document is KDGO. I hope everyone knows that you should have the KDGO guidelines on your tips and easy to access. Alright, yeah, please carry it. So what else? Now, what else for your patient? What else would you do?
So you do the chest X-ray.
Yes,
Out of there,
the chest X-ray had my bilateral fluid inflammation. There was no consolidation.
more important is the consolidation. You're not worried for consolidation. What is the next?
Like fun.
What happens to cardiac shutdown? Or the cardiomegaly?
Yes,
If the LV, where is the LV right? So what is the
Okay. Next investigation, what would that?
ECG.
yes, sir. Yes, sir. On
Damaging ECG. Let's place it in
ECG में क्या?
ECM, sir. There were no abnormal patterns were there, signs.
Your sinus, your normal sinus.
Yes, sir.
Evidence of LVH.
Was there any evidence of LVH from the low voltage complexes? Whether U waves? Were there not? Not nothing like what that severe. Nephrologists look at an ECG for
Or changes electrolyte. Changes.
they always look at the S and the T and then look at the P. The QRS we come to last because then we look for the support example. So you have to mention those things.
Great. So after ECG, what else?
Now, US.
So these are a couple of calls for them. No.
Echo, you are not finding an echo?
Yes, sir. 2G's cover.
Ultrasound में कुछ मिलेगा नहीं.
Because there is no
Sound,
history of
it is not fractured. Certainly you must find any audio again.
and technical size was also
The exit site is neat, the fluid is clear. You're not looking at an abdominal pathology over here, which could be found on an ultrasound.
to max.
Yes? Please. So we are only trying to rule out cardiac corpus.
To look at the left ventricular functions and
Both at the left ventricular function, what are the looking for?
so pericardial effusion
Evidence of acute myocardial infarction.
and IBC is still
You're
stable.
not expecting acute myocardial functioning in it's not really.
Myocard. PSH.
Yeah. What is that going to indirectly? That's it.
Pulmonary congestion. Flash.
Air pressures, yes.
What should suggest? What am I looking for? That term which is common in all CKD patients or dialysis.
Because I think culture search. First dysfunction.
It's 100% given his MV CKD patient. If they have LVH, it will become even more problematic. Patient stays on dialysis. What is HFpEF? Again, what is the problem there?
That's the issue. That's the
The heart is unable to relax well. Please understand, the heart is chronotropic, inotropic, and lusiotropic. What is lusiotropic?
The ability to relax of the
Yes.
body.
Let's also start lusiotropy. It's also relax. Okay. So, the ability to relax is very important. If the heart is unable to relax, it will not be able to perform better. So diastolic dysfunction is a very important cause, and that's why the echo is important. I am interested in knowing what is the parameters of the LV cavity, LVH check. LVH has 100% absolute dysfunction provider. Grade 1, 2, 3, 0. That could also be a for
Here's the echo panic index.
Yes, sir.
ये बताओ.
So he concentric LVH with LVEF of 50% and vasovagal dysfunction, IVC high normal, and PFP was 27.
Was low.
Not very high.
So different. So going on, what else would you do?
Tachycardia infusion.
E and A is equal to E less than A.
Right.
Because of the sector. Make it a business to know everybody else's business. That's why people don't like pathologists. We know more than them about their own topic. So whenever you see an echo, what is E, what is A, pata hona chahiye.
Take it.
And ask your cardiology colleagues, and I want to know kitna diastolic dysfunction. Because very often they do. Now, of course, they've got used to think diastolic dysfunction. We used to see more with them, and they would refuse to allow. This to the ejection fraction 60%, and TK is the patient can't treat that right. Now that the therapist was known to nephrologist many decades ago, सब बोलते थे वो सुनते नहीं.
Why?
So I said it is important to be a nephrologist because it's their job to do everybody else's job. So that you understand and their patients.
Take it. So what other tests would you do in this phase? Have.
That's it.
How does this the adequacy now? I like this. So after all,
It looks like we have ticked off all the possible boxes. And there are only two possibilities now. What are they?
very sharp.
One is
One is ultrafiltration fusion or inadequate dialysis. So there is this patient who's got a urea of 229 and a creatinine of 11.4. There's a hemodialysis patient who's got a pre-dialysis from the state stage. How do you decide who is adequately dialyzed?
Then that's the thing.
Let me assure you, this urea creatinine is not abnormal for a well-dialyzed CKD patients or PD. CKD patients have creatinine with a value of 10 to 12. While hemodialysis patients always have 4 to 6. Yes? But anyone? And we say very good, all is well. अगर hemodialysis patient का creatinine बाहर हो गया, is nothing doing now. Hemodialysis कराओ, करने जाना है frequency, yes, increase the frequency. आज तो कराओ भी. Why so? What is the difference?
Yeah, that's the
Yes.
because on pending analysis patient,
C? What is the C?
it is a continuous
Continuous process.
process.
It's a continuous process. This patient has reached a correct state of stability within renal function. This is how it's going to be. And the value of creatinine doesn't trouble the patient. Do we call it creatinemia or we call it azotemia or uremia? It's like urea which troubles the patient. Yes? And if a patient is eating well, his diabetes is more than 3, and his creatinine is 12, and he got CAPD, he's actually doing well on dialysis. Appetite is the most important indicator of adequate diets. In a balancing with commensurately support diet. So a CAPD patient with this figures, with a better albumin and good appetite, I would say is well diagnosed. Okay? So you have to understand this paradox between CAPD and QHD because I guess you don't see many CAPD patients. So you shouldn't get worried about this value. Their ureas are also in the under 30 to 200 range. So it's very difficult to say if he's inadequately diagnosed with just this.
So what are the ISPD guidelines for looking at progressing out?
Yeah.
So, creatinine by gene for urea is the marker of a measurement of adequacy, and a creatinine clearance we can calculate. So, a figure is for KT by 1.7 per week, and for creatinine clearance, 60 liter of creatinine clearance per minute per 1.73 meters square per week.
You know, I think the way that it's
45.
yeah. What is, because this is now, you know, that what you are telling us is what was fixed. Earlier on, you are fixated on these numbers. Now, adequacy is no longer as it we. So there are these other parameters for it.
If the patient is euvolumic, if patient has a good nutrition status, and he has if he has no uremic features,
Good quality of life. Also, 4 parameters. You know, your markers, your volume, then your
Functional state
function state and
conversion.
So these are
What is the nutritional status of this patient? According to the lab reports you have given us.
So as he's having hypoalbuminemia is there, the albumin sugar is 2.8. So
He's getting it out.
yes, and then
Because one of the people which has come over. He is very definitely is mother.
none.
Yes.
What is the PET test?
So it is the peritoneal equilibration test is there to measure the solute transport and the ultrafiltration. There is standard PET test which comprise of using 2.5% dextrose solution 2 liter bag, and then we measure dialysate and plasma urea, creatinine, and sodium, as well as the glucose of dialysate at starting of the test and at 4 hours. And then these parameters tell us about the transporter status of the patient. For performing the standard peritoneal equilibration test, first we should perform a night exchange of 8 to 10 hours, and then we should drain the patient. The drainage should take at least 20 to 25 minutes, and then we should instill a bag of 2 liter solution of 2.5% dextrose and over 10 to 15 minutes. And after every installation of 400 ml, we should roll over the patient. And so once the installation is done, we should make the patient to ambulate as much as possible.
What is the optimal time? So, yeah, what is the optimal time? So, you've initiated this patient or any patient.
Yes,
What is the optimal
first-
time to do a PET test?
After 4 weeks of ambulation, and then after any changes,
Or any episode of the
yes, sir.
So, anybody, how do you define peritonitis and what are the better analysis to the peritonitis scheme?
I call more than
That would be, yeah. Selcom, what is better? More than the 67% and a point second. Yes?
that be as well.
Now, yes, and I would probably say on the stage, yeah. So, the other way around, I would say start off with a cloudy fluid,
And
or
also,
the subject, or
then yes, still function. I need to work in 3.
So, let's say that this patient is, comes to you at the opening and he says that he's not getting any outcomes. So, what would you do?
There is one patient, just now we have played here chat. वो हफ्ते में नहीं हुआ यार इनके कल रात से आउट नहीं. Yesterday I died. Instead the fluid, there was a beta out. Fluid नहीं आ रहा. वो वैसे बंद नहीं हो गया.
So, sir, first of all, we'll try to rule out the so catheter malfunction can be one cause, and the commonest cause of outflow drainage failure is constipation. So that we have to ask, and then there can be any leaks in abdominal leak or pericatheter leak. But then patient will complain of swelling of the abdomen.
Outflow.
Not complete, but decrease in outflow.
In a very sudden response, it will be a catheter malformation.
Yes.
What else?
And there can be blockage because of the fibrin clot.
Yes, very important. Very important. So you should also ask you when you're seeing greater amount of fibrin coming out over the period of time. Right, umbilical.
Vertebrates.
Which is what which age group is umbilical problem?
First, so you can
Which age group is umbilical kiss active?
yeah.
Pediatric age group. It's a given that you have to do a umbectomy when you put a catheter in a child. It's a law. So if you don't do it, the umbilical will wrap it around.
Studies are very clearly shown that failure rate is far higher, so that's the problem. So, also, the umbilical size relative to the body cavity.
Cavity size is much larger than a child. The body grows, but the umbilical sort of stays the same size in the back. So it is just a little big, but in the child, it covers the entire upper. So what is you said? Outflow failure, catheter malformation, second is constipation, third is the clot. Sometimes your blood clot stays away.
Yes.
Outflow, you can have blood clot. Then of course you have other
Patient failure.
So, what are the advantages of peritoneal dialysis over hemodialysis and what are the drawbacks?
Sir, advantages is as it is a continuous gentle process. There are lesser episodes of hemodynamic instability, hypotension, hypertension. Then it because of this continuous nature, it also preserves the remaining nephron. So it is a effortless reserve factor. And please charge.
look at it from the patient.
Sensational. Yes, sir.
What the patient in the patient required to come to the hospital twice or thrice a week?
Thank.
No. Does a patient have to come and meet the doctor at a specific time of the day? No. He can choose.
They can conduct better changes of what
Only freedom and control over what he does and how he lives his life. But it requires the significant amount of
they concentration.
investment, both time, money. But what are the drawbacks? What are the drawbacks?
A caregiver is needed.
Very good. You always need a caregiver. It's extremely difficult to go the top one. What else?
And if for APD, the cycler is needed, which is costly.
Okay. Financially, they are more or less the same, but can right? Right? That's
Sick.
what else?
No,
Important things.
speedy patients, the
Their diet.
hair dynamic wound is the more common. Protein losses are also
Diet.
that's for the year.
Has anyone of you tried to eat 1.5 grams of protein per kg in a day? None of us need to give it close to 1 a day, even if you have a salmon daily. It is impossible to eat 1.5 grams. That is a major problem. They have to end up eating 8 to 10 eggs a day, or probably 150 grams of paneer a day. तब भी 1 gram तक ही जाके बनता है. So the diet associations that are required with CBD are very stringent.
Also, it's a fairly intensive procedure, so that's why you have a higher burnout.
And because burnout and patient burnout.
Yeah, which is, I think, maybe one of the reasons that we are seeing in them that possibly some, it appears that there has been, we have here a little bit rhinitis in general.
I think it got tired of it.
Yeah.
They got tired of it.
Without this, what is happening in this?
This is good for him because he will now go back motivated and he will give you another couple of years for the meritorious paper. Phillips, I'm surprised I've not seen a patient after stone box. Like yes, whatever we have.
I don't know.
So it was initiated on CAPD and RR hospital only. So Fishner was also made there. And then on follow-up since 2022, he's coming to this hospital.
So, if in case this was inadequate diagnosis, would you like to change his TV prescription now? He's on 1.5 the prospect. He is experienced 20 years at 22nd, third decade of the 20th century. Is this what you have considered the ideal prescription for him?
It's probably the. So it was to begin with, it was a good act on the prescription because he was a thin build patient with a good urine out. So he was started on 3 exchanges and he was doing fine with that. But if over the time he has lost
You're not responding.
so we can add we can add light extent of bronchial dilation. We can increase the dwell volume. We can add apodextrin. What kind of
So, that will have iconic.
8 to 10 hours.
Right.
To result the ones.
Against what?
You put against the
No, I will take out
degradation
that.
Yes, sir.
And I will place Icodex. So that in GDP related damage,
And was the glucose decreased.
the AGVs and the glucose linked product related damages are reduced. That 1.5 is there. In the day, it has to exceed with that, and then like I give him a 10 or 12 bit.
And the
Icodex.
medication is also
Put out of filtration, reduce glucose exposure, and the patient is also have. Yes. So that is something that we would do. Yes. Because there is one thing. Once a patient is motivated to do peritoneal dialysis,
understand.
he is very unhappy on hemodialysis, I can assure you. They very soon, like God forbid, he has peritonitis. After now, he has peritonitis, he will beg, please, मेरा catheter दोबारा डाल दो. इनको hemodialysis पे नहीं जा पाए because he is used to living his life while none of us place importance on this, but we have given this patient antibiotics. Come and show me your face once a month with your blood reports, and that's all you require. बाकी आप रात के 7 बजे करो, रात के 10 बजे करो, दिन में 8 बजे करो, दोपहर के 2 बजे करो, that is your problem. But do it thrice a day with at least 6 hours and then 10 hours. So you see the amount of freedom you give your patient as compared to a hemodialysis patient. Easier slave, आज अगले हफ्ते से आप 10 बजे आओ, इस हफ्ते आप 7 बजे आओ. You can't go anywhere. He can't travel freely. You travel.
That's right. So there is this quality of life
This question of that have an emo versus
I tested the because residual function. Second, the advantage these patients have when they get transplanted. There is a study long back. Patients who get transplanted while on CPD have a better graft functions than patients who have been on more dialysis for transplant. It's never been done. I think it was just an observational study done on a very small number of patients. Question. Technically, you want to self-remedy to a patient, these are the things you can see. Undergo a transplant, even less, you are sleeping. What would you do?
or understand.
You keep the patient right. You have to give the patient hemodialysis. You can't set him to chemotherapy with a urea of 220 and a creatinine of 1150. There are 6,000 will take them. Absolutely not. You will have to keep the patient right. Give him that 5-6 hours of pre-transplant dialysis that always to do. Send the patient with a decent urea at double digits or low alters, creatinine of 2 or 3, early morning dialysis. Okay, well, patient comes back, we have replaced the graft, extra peritoneum, so the peritoneum is intact, but there will be instances where the urologist should say, I've reached the peritoneum. So for the next 2-3 days, you should not be starting peritoneal dialysis, but you have a catheter inside, so you have to be careful. Alright, after 3-4 days, the call is filled, the drain is okay, there is no major problem, the peritoneum was not reached. You can do once a day exchanges just to flush the peritoneum. And thereafter, after 7-10 days, you are not confident that your graft is staying in, everything is well, you can expand the catheter. That's how we usually do it.
There will be some people would do it at about 2 to 3 weeks. Getting this with the stent.
When they remove the stent,
I think that's the usual protocols at that.
some people have also removed it during the transplant session. But that's not a good idea. You can never be sure about your graft.
Jesse give that.
So what is this patient at Atta? Abhi, how was the US? Now you have to exchanges or you have to hemodialysis?
No, sir, we started with this nitrile of epodextrin volume. And
Whether you have to come out.
sir, at the time of discharge, he was his weight was also reduced, and he was having a UF of around 900 ml, 700 ml to 800 ml in this epodextrin malas, and 150 to 200, 100 to 150.
What happens to his weight? You have a 1.2 liter, this does dextrose containing fluid. Now with icodextrin, it's barely touching 1 liter. What's happening to his peritoneum?
It is
तुम्हारा सीपीडी का लेक्चर खत्म हो चुका है पेट टेस्ट पढ़ा चुका हूँ आई थॉट न्यूट्रिशन फेलियर का पूरा लेक्चर था
yes, sir.
तो क्या हो रहा है इसको लॉन्ग टर्म
Effective peritoneal surface area is getting reduced.
और he's becoming a hydra. He's becoming a hydra. So the solute load is getting dissipated very fast. So the osmotic burden in the peritoneal cavity is getting less. So the ultrafiltration is failing. So what would you do in such a patient?
In high transport status patient, we advise them to shift to APD so that we can have a small spotted emission. And
अब APD में क्या करोगे? पेशेंट को आइकोडेक्स्ट्रिन चल रहा है, पेशेंट को आपने TBD में शिफ्ट करना है. अब आप क्या करोगे?
sir, APD with the day well of epodextrin we can do, which is CCPD.
10 hours of the day when he's awake and up and about, you give him icodex.
Yeah.
At night when he comes back, he hooks it
Just like that.
and 10 से 12 मिनट की इधर देखिए. First year, what is APD? Ambulatory नहीं. Automated peritoneum. क्या होता है इसमें?
Cycles.
Here's the cycler. And there are 5 liter bags. You put 2 of those bags. What does the cycler do? It takes 2 liters in. It pushes it into the peritoneum. Leaves it there for a fixed amount of like usually 2 hours. And then takes it out into drain bags. So what is happening? You're reducing the dwell time to 2 liters, which means you are allowing the osmotic gradient to maintain for a shorter duration. So that is a high transporter, the dissipation of the gradient is not there. So जब तक gradient रहता है उतनी देर में we take out the fluid. So ultrafiltration continues to happen. And you do 5 such cycles in a 10-hour series. Yes?
So what are the other complications these patients have? We discussed, briefly discussed peritonitis with the solve the treatment of peritonitis, and what else can happen? Yes.
Sure.
at the malfunction maybe of the organs. Organ.
So there can be hernias can develop over time, and after long duration of CFAD, there can be development of their condition, ECS, encapsulating peritoneal sclerosis, and the non-infected complications.
Something more common would that lung infections.
They can have exit site infection, tunnel infection.
Yeah. So how do you differentiate between the two?
Exit site infection is defined as presence of discharge at just exit site of the catheter. Present erythema may or may not be present if that may be because of the irritation of the antiseptics which are applying. And tunnel site infection is presence of redness and tenderness over the tunnel site. Induration.
And the frequenters
Treatment is
of the bridge.
so first we give antibiotics or antibiotic course, and we see the response. If it is not there, so it is not responding to the antibiotics, then we can remove the catheter and reinsert it at a different space, shifting the site of the catheter.
Other infections.
Simultaneous, but
Really required.
they respond to the antibiotic.
Or you very basically exit from the catheter and soon exit from understanding. But that usually tunnel infections are best treated and remove all the capsules. You will never be able to get gasified through the and about cough extrusion.
That's how like.
Yes, sir.
What do you do about, let's say this patient comes to you in the cough extrusion, what will you do?
And so they exteriorize and shave the.
So it's a partial cough, it's only just shave off the cough and you will try to fill with it. So, hey, it's fine.
And the
Yeah, it's fine.
Any doubt questions, comments,
Hello, please. You join us. Any questions about shampoo?
all that first year more that seems happening. All are seeing a CFD patient.
Second year,
All are actually seen an exchange taking place. So actually existed or saying how to use a very cap, transfer set क्या होता है, डायग्राम कैसे लगता है.
what's up? What's now up? Others should make an effort. There are some centers who are doing it more often. So that is up to you to try and talk to your friends. Make sure that you see this. Okay?
If you get a cloudy bag, always take a picture of it. Very easy. Because CFD patients generally try to stay far away from us. So the simplest thing phones and WhatsApp have made it like really so. Every morning you tell them, हाथ में एक photo लेके रख लिया so that you have a baseline from there. And the moment it gets even a little bit turbid or cloudy, they immediately send you a picture. So whenever you, I'm sure there's enough of these pictures on the internet, but for all those of you who haven't seen it, see how it looks. It's exactly what it's saying. And of course, there are various degrees of cloudiness. But even a little bit should incite a suspicion. The threshold for initiating treatment for peritonitis should be very low. Don't wait for full ball with Javi, which they wire. If I can still do ABG, how we got you gonna walk? Okay.
Read up the ISPD guidelines. Yes, we take heavy, those medical or curriculum learning. We should all of you should spare between as. Alright.
Whether get that, some product details are there, but with practice, that loss get. Versus child,